This conference will now be recorded.
Okay, good morning everybody. Before going in detail about the approach and diagnosis of bleeding neonate, today's topic, neonatology topic, why you should know about the neonate with bleeding disorder. What is the purpose? If not diagnosed or not treated, what happens to a neonate with bleeding? Is anybody going to answer? Roll number 10. Roll number 10. Roll number 10 is
Yes,
there
or
absent? Just
present,
think and answer. Think and answer. Why you should learn about bleeding neonate? Or otherwise, if you don't know, if you won't diagnose, what happens to a neonate with bleeding diathesis or bleeding manifestations? I think all of you know what is the definition of neonate or yet newborn. First 28 days of life we call as neonate. So the first 28 days of life, if any baby having this complaint like bleeding neonate, what happens if you won't diagnose or if you won't refer the baby to a higher center or where the pediatrician or neonatologist is available? Roll number 11. 12. Roll number 12.
Yes, ma'am. Good morning, ma'am.
Good morning. Can you answer why we should learn about, as an MBBS student, why you should learn about bleeding neonate? What is the purpose? What happens if you doesn't know by the time if you finish your final year exams and coming for the internship? If you don't know about the bleeding neonate, what happens to the newborn with bleeding manifestations? Anybody?
If the baby goes to anemic or hyper.
Be loud. Arnab, I think Arnab is answering.
Yes,
Be
ma'am.
clear and loud.
Or the
What happens?
child may go to shock.
Oh, good. Baby may go for shock. Severe hemorrhage can lead to hypovolemia and shock. And then what happens if you are not diagnosed even the shock? Baby might
Child may go to hypoxic.
Hypoxic is encephalopathy. Actually, any young age they may and hypoxic can lead to ischemia. Both will lead to hypoxic ischemic encephalopathy, which can manifest in the later age as cerebral palsy, developmental delay, and especially bleeding neonate, especially newborns. That too, the baby is preterm baby. Their capillaries are very fragile, especially in intraventricular and intracranial capillaries. So that can lead to intracranial hemorrhage and intraventricular hemorrhages. They can manifest with seizures, that is convulsions and bulge of the anterior fontanelle, sudden onset of pallor. So these features are there. You have to suspect. At least you can stabilize the emergency measure, and you can refer to the newborn baby to a pediatrician or neonatologist. So for that purpose, you should know how the newborn with bleeding diathesis or bleeding disorder manifest in the first 28 days life. So these are my objectives of today's class. So at the end of the class, at least you people should know what are the symptoms and signs of bleeding neonate, and how to initiate workup, what could be the cause, how to investigate, and what are the differential diagnosis. Not always all bleeding neonates may be having serious conditions. Sometimes some benign, just swallowed maternal blood may be, they are having the manifestation like upper GI bleeding. So you should know which is severe problem, which is non-severe like benign problem. For that purpose, you should differentiate other this condition, serious platelet disorders or coagulation defects from the benign condition like swallowed maternal blood. Okay. So before going in detail about the bleeding unit, this is for only for you to remember your in pathology and physiology learned about the coagulation cascade, normal coagulation cascade. This is normal coagulation cascade, both intrinsic and extrinsic pathways. Intrinsic pathway from factor 12 will become activated factor 12 with the negatively charged activator. Then from activated factor 12, it acts on the factor 11 to factor converting it to activated factor 11. Next comes to the factor 9 to activated factor 9. Next factor 8 to activated factor. These we all will finally leads to the common pathway. Even extinct pathway from the after the tissue injury, tissue factor will be released. This directly can act on the factor 9, or it can leads to activation of thromboplastin. This thromboplastin will act on the factor 7 to convert it into activated factor 7. Then final pathway is thrombin formation. From thrombin, which acts on fibrinogen to form fibrin monomers and polymers, then clot formation. So this is the intrinsic and this is extrinsic pathway. These are the factors which are shown in orange color are affected by heparin. That's oral anticoagulants or IV heparin subcutaneous heparin also can lead to effect of these factors. These are the blue color factors are vitamin K dependent factors like 9, 8, 7, and 10, and prothrombin. These are affected by the vitamin K deficiency or oral anticoagulant anticoagulant drugs. So you should know this. There are two pathways common. Finally, thrombin formation can occur from the extrinsic pathway and also from the intrinsic pathway. So coming to the bleeding unit, these babies may be sick babies or even well babies also can manifest with bleeding symptoms. So who causes may be varies. If the baby is sick or ill baby, ill looking baby, sick baby, causes may be different for the bleeding manifestations. The baby is well, doing well, taking feeds, still having the bleeding manifestations, causes will be different. Can you tell any cause where the baby is well looking, having bleeding manifestations? Very common also. Well looking baby with bleeding symptoms. Roll number 20. Roll number 20 present or absent?
Yes, ma'am.
Well baby with bleeding symptoms. It's very common. That's why I am asking this question. Just give an example for well looking baby with bleeding manifestations. Hello. Kishore, I think Kishore, roll number 20.
Yes, ma'am. Vitamin K deficiency.
Well baby means baby is not having any infection. Well baby means not having any infection without sepsis. Where baby may have bleeding.
Vitamin K deficiency.
Good. Vitamin K deficiency. Any other condition? Vitamin K deficiency can occur in well baby and also in sick babies also. In case of liver disease, one is vitamin K deficiency. Okay. ITP. Never heard about ITP. ITP means?
Thrombogenic purpura. Idiopathic thrombogenic purpura.
Good. Idiopathic are actually immune-mediated thrombocytopenic purpura. ITP is immune-mediated thrombocytopenic purpura. So these babies will manifest with excessive bleeding, just appearing as increasing size of supplementoma, that is expanded supplementoma, or prolonged bleeding after circumcision. Usually some people will go for circumcision in young age only, immunity religious wise, or sometimes there is phimosis, then only they have to go for circumcision. In that time, bleeding after circumcision and oozing from the venipuncture, like we can draw samples for complete blood picture or for glucose estimation. With small venipuncture sites also there will be bleeding, and sometimes from IV lines, IV cannula line. So these may be the manifestations, or sometimes spontaneous bleeding from the stomach. So this is in case of normal looking well baby. In sick neonate, the baby may be having bleeding from the mucosa of the bladder, they may manifest with hematuria, and mucous membranes, other like upper GA bleed, intracranial bleeds, especially intracranial bleeds can present with sudden onset of pallor, baby will become pale, and also anterior fontanella bulge will be there, and seizures, altered sensorium. So you have to suspect intracranial bleeds. And pulmonary hemorrhage, in case of pulmonary bleeds, they manifest with increased respiratory rate, that is tachypnea and intercostal retractions, and fall in the saturations. So here is the clinical photograph. You can observe this is a subphlegmoma. So if you examine the head or the scalp of the newborn baby, soft, boggy swelling will be there. So this has to be differentiated from caput succedaneum. Caput succedaneum will be diffuse swelling, usually over the presenting part. It lasts within 24 to 48 hours. But here it manifests after 24 to 48 hours, rarely immediately after birth. Mainly, the indentation will be positive. It is localized with sutural lines, and then sometimes there will be underlying bony fracture also. It's due to subperiosteal bleeds. That's our caput is due to edema, subcutaneous edema over the presenting part that subsides spontaneously benign 24 to 48 hours. Here it stays at least for 2 to 3 weeks, subphlegmoma. But it is increasing in size. We have to suspect some bleeding manifestations. Sometimes ecchymosis they may present with ecchymosis. These are the like from the mouth, they can present with upper GA bleed with bleeding from the mouth, and baby may have spontaneous bleeds from the umbilical stump, and sometimes they may have melena or interchisia. Frank blood we call as interchisia. If it is dark tarry color stools, we call as melena. That indicates usually interchisia lower GA bleed, and melena indicates upper GA bleed. So like diaper, there may be frank blood. So we have to rule out cause for the bleeding neonate. So etiology causes for bleeding neonate most probably maybe due to decreased platelet count, we call as thrombocytopenia. This thrombocytopenia may be so many causes. I will delve in detail in later slides. And it may be due to inherited problems due to clotting factor deficiencies, maybe hereditary coagulation factor deficiencies. Examples for hereditary clotting factor deficiencies. Roll number 30. Roll number 30 is present or absent? 31. 32.
Ma'am, 30 present, ma'am.
30. Name some inherited clotting factor deficiency. Coagulation disorder. Inherited coagulation disorder or clotting factor deficiency. Name one condition where it's due to hereditary clotting factor deficiency. Very common.
Von Willebrand.
Inherited means genetically inherited clotting factor deficiency.
Hemophilia.
Hemophilia, good. There is different bleeding disorder is bleeding manifestation may be due to thrombocytopenia platelet deficiency or maybe clotting factor deficiency. Coagulation defects is factors deficiencies. Hemophilia is an inherited problem. What is the inheritance of hemophilia? What is the inheritance? Is it autosomal dominant recessive or X-linked recessive or X-linked dominant? Roll number 34. Roll number
Recessive.
Which recessive? Autosomal or X-linked?
X-linked recessive.
X-linked recessive. Okay. Thrombocytopenia, it's a decrease in platelet count less than 1 lakh per cubic mm. We call as thrombocytopenia. So causes for thrombocytopenia may be neonatal allohuman thrombocytopenia. It is due to maternal antibodies towards the baby's platelets. And maternal diseases like the mother is having ITP, that is immune thrombocytopenia, thrombocytopenia purpura, SLE, that is systemic lupus erythematosus in the mother, can lead to thrombocytopenia in the babies. These are the transient causes. This neonatal allohuman thrombocytopenia also transient. Usually by 1 or 2 months it will subside, and this maternal diseases caused because through the placenta antibodies from the mother will transfer to the fetus and the newborn fetus, and these antibodies will be destroying the platelets. So this is transient, temporary. Once these antibodies are destroyed, then a baby will have normal platelet count. So inherited disorders of thrombocytopenia like Viscott-Aldrich syndrome and Fanconi's anemia. These are inherited problems of inherited genetic conditions where thrombocytopenia may be the associated feature along with the anemia in case of Fanconi's anemia. And other genetic syndromes like 13 trisomy and 18 trisomy called as Edwards syndrome and trisomy 21 Down syndrome. In those also there will be thrombocytopenia. Not all cases of Down syndrome. Maybe some conditions that syndromic babies may have associated thrombocytopenia. And the DIC, this is disseminated intravascular coagulation. This will be seen in case of sick babies, necrotizing enterocolitis, also septic neonatal sepsis, and renal vein thrombosis in case of polycythemia and hyperviscosity, dehydration. They're more prone for renal vein thrombosis and large AV malformation, that is arteriovenous malformations. In those conditions also, in large AV malformation, platelets will be consumed. So this leads to bleeding manifestation. And sometimes qualitative platelet disorders, that means functional defects of the platelets. Platelet count will be normal. Thrombocytopenia means platelet count is less than 1 lakh per cubic mm, we call it thrombocytopenia. But bleeding can happen even with normal counts with decreased function, that is Bernal-Soulier syndrome and Glanzmann thrombocythemia. So metabolic conditions, sometimes inborn risks of metabolism like methylmalonic aciduria can have functional defects of platelets. And maternal drugs which can affect the platelet counts are quinine taken by the mother for the malaria treatment, and quinidine like drugs will cause thrombocytopenia in the newborn. These are transient causes only. And there are transient deficiencies of clotting factors. Like the previous one were transient causes of platelet defects. Here is the coagulation factor deficiencies. It may be mainly due to vitamin K dependent factors deficiency. Whenever vitamin K deficiency is there, especially these manifest with hemorrhagic disease of the newborn. This again divided to depending on the time of onset, early HDN, that is hemorrhagic disease of newborn, classical HDN, and late HDN. This may be asked for 4 marks question. HDN, that is hemorrhagic disease of the newborn due to vitamin K deficiency. Family history is very, very important whenever a baby with bleeding manifestations, because some X-linked recessive conditions like hemophilia, usually maternal uncles, sisters will be normal, elder siblings, boys, or maternal uncles will be affected. Father also will be normal. Mother may be the carrier, so she won't manifest any features in case of X-linked recessive disorders like factor 8 and 9 deficiency hemophilias. And maternal uncles with history of bleeding will be there. Siblings with history of bleeding, especially boys, will have bleeding. And autosomal dominant condition is also there. This is X-linked recessive, but their autosomal dominant inheritance may siblings or father or mother may be having the manifestation. This is von Willebrand's disease in case of von Willebrand disease. And autosomal recessive factor deficiencies are factor 5, 7, 10 deficiency, inherited factor deficiencies. They can have autosomal recessive. This here, history of consanguineous marriage will be there. And maternal disease, like as I told you, maternal history of ITP or lupus system SLE, that is systemic lupus erythematosus. Usually mother's platelets also will be decreased. Thrombocytopenia in the mother also will be there. And this SLE, if the mother is having SLE, newborn baby will have low pulse rate, heart rate. Heart rate will be less than 60 per minute. Usually newborns will heart rate will be more than 120, it's around 140, 150 like that. 120 to 160 per beats per minute is normal in normal newborns. But if the mother is having SLE, usually these babies will have heart rate of less than 60 per minute, mainly due to complete heart block. So maternal SLE can manifest with thrombocytopenia and complete heart. Maternal infections, antenatal infections. If there is history suggest of fever with rash or fever with cervical lymphadenopathy in the first trimester of pregnancy, usually suggest of torch infections, toxoplasma, rubella, cytomegalo, herpes, and HIV, and hepatitis B. Other infections we call as torch infections. There usually newborn baby will have thrombocytopenia and other features of torch like low birth weight, IUGR, intrauterine growth restriction, cataracts, jaundice, septosplenomegaly. Other clues also will be there if the mother is having had torch infection. And if maternal pre-eclampsia and eclampsia, so HELLP syndrome, mothers with HELLP syndrome, that is mother with hepatic problem with the platelet count is a complication pre-eclampsia, eclampsia. And that time also babies may have thrombocytopenia. And maternal exposure to drugs like aspirin, phenytoin, phenobarbital for as anticonvulsants, and warfarin and rifampin, INH used for some other reasons, INH for tuberculosis treatment. These babies will manifest with early vitamin K deficiency bleeding. The usually first 24 hours of life only they will have bleeding manifestations. And coming to the birth history, during the birth process, natural history, perinatal asphyxia, history of perinatal asphyxia is there, means that leads to lactic acidosis and platelet dysfunction. So these babies are more prone for bleeding manifestations. So coming to the next history, once antenatal history, we have to take history properly regarding the maternal exposure to drugs and maternal PAH, preeclampsia and all those conditions. And natal history is the prolonged labor is there, baby not cried immediately after birth. That all indicates perinatal asphyxia. That also leads to platelet dysfunction and bleeding manifestation. And the present history, usually day of onset of bleeding is very, very important. The day one bleeding, usually it's early vitamin K deficiency bleeding. So mainly we have to exclude maternal causes, maternal drugs and maternal ITP and maternal SLE. Day 2 bleeding, that is 2 to 7 days, classical vitamin K deficiency bleeding. Here, whether the baby received vitamin K immediately, that's why we will give vitamin K immediately after birth. And site of bleeding is also very, very important. It is from umbilicus. Sometimes that ligature over the umbilical stump is not given, not tried properly, then it will slip and causes bleeding from the umbilicus, because very small amounts also leads to hypovolemia in the baby, and baby may go for shock. So that's why very cautiously have to look for the umbilicus. If there is a slip ligature or umbilical infection also can manifest with bleeding from the umbilical stump. And sometimes, as I told you, it may be some swallowed maternal blood. So benign, nothing will happen. So we have to exclude that one by doing test. I will tell what is that app test. And vitamin K deficiency bleeding. Mucosal, the upper GI bleeds, they will present with bleeding from the mouth, or melena and erythematosus, or skin, they may present with purpuric rash in case of thrombocytopenia, and disseminated intravascular coagulation, purpura, or ecchymosis will be there. And sometimes post surgery, baby may be normal, but for some reason, if the baby undergoes for surgery, post operatively, they will have bleeding manifestation. Then we have to suspect clotting factor deficiencies like hemophilia A and B. Next, physical examination, general examination, have to look for petake and purpura, usually indicates thrombocytopenia. Intracranial bleeds, like babies may be having vomiting, seizures, anterior bulge, and sudden onset of pallor indicates intracranial bleeds. And bleeding from punctured sites like IV lines, heel, stick indicates also thrombocytopenia. And large sublymptoma, immediately after birth is small, it's increasing in size, becoming large. We have to suspect some problem with platelets or congenital coagulation, hereditary coagulation factor deficiencies. We have to see whether the baby is a term or preterm baby, whether the baby is sick or well baby. So causes for sick baby, usually underlying sepsis, infection will be more common. Well baby, have to think about clotting factor deficiencies, vitamin K deficiency, and ITP, immune thrombocytopenias. Congenital anomalies, sometimes if you examine physical examination, there will be some clues, like in case of trisomy 21, baby may have flat faces, flat occiput with mongoloid slant, simian crease, all will be observed in case of Down syndrome, or in case of some absence of thumb, in case we can observe in case of TAR syndrome, TAR, TAR, that is thrombocytopenia associated with absent radius. Here you can see the clinical photograph. All of you should concentrate whenever I am teaching, because these classes will not be repeated again. Neonatology very important for you for both SPM, pediatrics, and gynecology, obstetrics also. And these photographs may be shown for your PG entrance. So if you concentrate from your UG theory classes onwards, you can get good ranks in your PG entrance also. This year can see only 4 digits are there. Thumb is upside because of absence radius. In the X-ray also you can observe only ulna is there. There is no radius. Only ulna is there. There is the ulna is there, no radius. So absence radius, that is called as TAR syndrome, thrombocytopenia associated absent radius. So the baby may not have thumb and associated with bleeding manifestations. examination, you have to look carefully because there will be clues. The baby is sick looking, ill looking baby. Sepsis, most probably the sepsis, neonatal sepsis. Baby will be drowsy, not active, neonatal reflexes will be absent. Or sepsis and usually associated with disseminated intravascular coagulation, or maybe due to liver disease if the baby is sick means. Well baby, vitamin K deficiency or clotting factor deficiency like hemophilia A and B. And the baby is having petechiae, purpura, small ecchymosis, usually indicates platelet disorders, thrombocytopenia. It may be a sick baby or well baby, both conditions, thrombocytopenia may be there. Deep bruises, clot even into the muscles and joints. We have to think about clotting factor deficiencies, hemophilias, and even disseminated intravascular coagulation, liver disorders, where vitamin K deficiency will occur in case of liver disorders, especially cholestatic jaundice and vitamin K deficiency. Here, deep bruises will be there. And splenomegaly, sometimes if you examine carefully, ectosplenomegaly or splenomegaly will be there. That usually indicates congenital infections, torch infections, or erythroblastosis. So, if there is a jaundice, especially conjugate erythropoiesis, indicates torch infections and liver disease, cholestatic jaundice. Abnormal retinal findings, if you examine fundus and retina carefully, there is retinal retinopathies and all changes will be observed in case of torch infections. And there is one entity called swallowed blood syndrome. Maternal blood will be swallowed. So you think that serious problem, it is a benign. Usually, second or third day of life, they will manifest with, or sometimes they pass the blood in the stools. That may be due to anal fissure. That may be due to fissures, cracked nipples over the mother breast, that leads to baby may swallow maternal blood in case of cracked fissures or the nipples. That can also manifest with bleeding from the mouth. So it usually confused with upper GA bleed. So how to differentiate whether the blood is from the baby or the mother? The swallowed blood or baby is having mucosal bleeds, upper GA mucosal bleeds. That is called as AP test. How to do? So mainly principle underlying this test is infant blood contains HbF, that is alkali resistant, but maternal blood HbA forms alkaline imagine and additional. So you have to take upper gastric test by putting feeding tube or nasogastric tube, and add one part of bloody stool or worm test. If there is a lower GA bleed, if you are suspecting, we can take one part of bloody stool, or if the upper GA bleed you are suspecting, worm test or gastric lavage, and 5 parts of water. We have to add 5 parts of water, like 1 ml worm test and 5 ml of water, and centrifuge and separate. There will be clear supernatant will be there, pink clear pink supernatant will be there. For this supernatant, add 1 ml of 1% sodium hydroxide. So usually in case of HbA, which is not alkali resistant, will become yellow brown. That's maternal origin. If the alkali resistant, that is fetal hemoglobin, it will stay back like a pink only. So you have to what do you have to do? 1 ml of bloody stool or 1 ml of worm test, or you can have gastric aspirate, 1 ml of gastric aspirate, add 5 ml of water and centrifuge and keep it aside. Then sediment and the supernatant will be formed. This supernatant will be clear and pink. So for this 1 ml of 1% sodium hydroxide, if you add, then it will become yellow brown in case of maternal origin and stays back like a pink in case of fetal origin. That is the AP test. So coming to the other laboratory investigations, what are the investigations you will do? So baby came with presentation of like bleeding from the mouth or bleeding from the rectum or blood in the stool or umbilical bleeding from the umbilical stump or ecchymosis over the skin or petechiae, purpura or anterior bulge with seizures. You are suspecting intracranial or intraventricular hemorrhages. So you know that baby is having bleeding one. So you have to stabilize by giving severe anemia. We can give blood transfusion. If you baby is in shock, you have to give fluid bolus is 20 ml per kg normal saline you can give, and meanwhile you have to draw the blood for diagnosis. blood count for platelet counts. So if the platelet counts is less than 50,000 per cubic mm, should be careful. If it is less than 20,000 per cubic mm, then more chance of intracranial bleeds. So why we are bothered about intracranial bleeds? It can manifest with seizures and altered sensorium. Respiratory centers can be affected, or baby may die with irregular respirations, or maybe baby survives future they may have sequelae, neurological sequelae in form of cerebral palsy. So for that purpose, you have to prevent the intracranial bleeds. And prothrombin time for factor 8 and vitamin K, factor 7 and vitamin K dependent factors, prothrombin time will be prolonged. It's for extrinsic or intrinsic pathway, prothrombin time. Extrinsic pathway. Okay. Activated partial thromboplastin time usually prolonged in case of hemophilia. And fibrinogen levels, hypoprobinsemia indicates and increased D-dimer disseminated intravascular coagulation. And thrombin time for dysfibrinogenemia. Platelet function as a platelet count will be normal, but like Benel-Chaulis syndrome and Glangerman's thrombocythemia, platelet functions may be different. So you have to go for functional assay, platelet functional assay. So here is the algorithm. You can see if the baby is sick and ill looking, baby is lethargic, not active, neonatal reflexes are absent. I have to think that baby is sick. Usually sepsis, neonatal sepsis, in that if you, platelets are decreased and prothrombin time is prolonged and activated partial thromboplastin time is also prolonged. All three derangements are there. Most probably it's a sick baby, disseminated intravascular coagulation. We have to think. The platelets are decreased, but PT and APTT are normal. So we have to sick baby platelets decrease means necrotizing enterocolitis. And sick baby with platelets normal, PT and APTT prolonged, always it indicates liver disease. So these are the clues. If the baby is well baby, active baby, taking feeds well, then if you do platelets normal, PT normal, and APTT only prolonged, that indicates hemophilia, congenital or inherited coagulation factor deficiencies like factor 8 and 9 deficiencies. And platelets are decreased, PT normal, APTT normal, well baby, immune thrombocytopenia, ITP. Only platelets are decreased, other investigations normal means immune thrombocytopenia. Platelets are normal and PT, APT both are prolonged. Vitamin K deficiency, bleeding disease, we have to think. So common coagulation disorders usually can divide into inherited problem and acquired problem. Inherited, already discussed, like hemophilia A and B, autosomal recessive inheritance, or autosomal hemophilia A and B, it's X-linked recessive inheritance, and von Willebrand disease, autosomal recessive, so otherwise called as autosomal hemophilia also. This name given to von Willebrand disease because autosomal recessive inheritance will be there in von Willebrand. They will manifest like bleeding manifesting. Differential diagnosis will be hemophilia, but factor 8 levels will be normal. So mucosal bleeds, only they manifest with mucosal bleeds, not deep bleeding like hemarthrosis and bleeding in the muscles. This is autosomal recessive. Von Willebrand disease, hemophilia A and B are X-linked recessive, and factor 7, 10, and 12 deficiencies also due to inherited problem only. Fibrinogenemia also inherited. Coming to the acquired causes of coagulation disorders, liver disease, especially cholestatic jaundice, or any chronic liver disease can manifest with acquired coagulation disorder. And vitamin K deficiencies due to acquired liver, in case of liver disease, it's acquired deficiency, or inadequate vitamin K supplementation in case of exclusively breastfed babies, also they present with vitamin K deficiency. And taking anticoagulants like warfarin overdose, also manifesting with acquired coagulation defects. Hemophilia, congenital bleeding disorder, rare during neonatal period. Hemophilia usually they won't manifest because depending upon severity, mild and moderate and severe will be there. So usually they won't manifest bleeding manifestations. Usually after if any surgery, post-surgically they manifest. Like after circumcision or some surgery happen to the baby, then only they will manifest. So depending, usually if there is 80 to 85% of factor is there also, they won't manifest. Less than 15% only they will manifest with bleeding in case of hemophilia. And usually in case of coagulation and inhibited problems, prolonged activated partial thromboplastin time will be there, and confirmation by factor 8 levels and factor 9 levels. So classification of hemophilia, depending on the factor levels. If the factor levels are less than 1% of the normal for that age and baby, then it's severe. Usually spontaneous bleeds will be there. The factor levels are between 1 to 5% of the normal, then they will manifest with moderate hemophilia, like trauma, post-surgery, they will have bleeds, occasionally joint bleeds. But mild 6 to 40%, they won't manifest until there is a major trauma or major surgery, and rarely they will have joint bleeds. So only if the factor levels are less than 1% of the normal, then only they will have spontaneous bleeds. That is called a severe hemophilia. So this classification you have to remember. You may get as a 4 marks question or 10 marks question: hemophilia classification, clinical features, management, how to prevent. Coming to the thrombocytopenia, platelet counts less than 1 lakh per cubic mm, we call as thrombocytopenia. The main goal in case of thrombocytopenia, we have to maintain the platelets about 20 to 30,000 per cubic mm, because if the platelets are less than 20,000 per cubic mm, it can lead to intracranial bleeds and can lead to morbidity and mortality in newborn. So we have to differentiate depending on the baby, well baby or sick baby. Sick baby, infection, sepsis, dissemination, intravascular coagulation, thrombosis. Whenever thrombosis leads to consumption of platelets and leads to bleeding manifestations and necrotizing enterocolitis, pulmonary causes like respiratory distress syndrome, that is hyaline membrane disease, or meconic aspiration syndrome. These are the causes for sick baby with decreased platelet count less than 1 lakh per cubic mm, that is thrombocytopenia. The baby is well baby, like maternal causes like SLE, maternal ITP, non-human immune thrombocytopenia, neonatal alloimmune thrombocytopenia, neonatal, and for neonatal alloimmune thrombocytopenia. And this is also, these two conditions are transient. And thrombosis, whenever thrombosis can lead to decreased platelet count. And viral infections, polycythemia in a newborn, usually they may manifest with thrombocytopenia. So coming to the one word about the neonatal alloimmune thrombocytopenia, it's very rare. Usually maternal antibodies to the fetal platelets, like RH incompatibility. The mother is H negative, the father is RH positive. How platelet blood group incompatibility is there? Platelet incompatibility will present. The mother is PLA negative and father is PLA positive. So antibodies towards this PLA antigen will be formed, and this passes through the placenta, and the baby will have thrombocytopenia. And intracranial hemorrhages are more common. Around 15% of these babies with neonatal alloimmune thrombocytopenia. Severity of the disease will be there of other siblings also. And usually this can be subsequent pregnancies also can be prevented by giving IV immunoglobulins and steroids to the mother at 20 to 24 weeks. And we can take the blood samples to assess the antibody titers for the platelets around 30 to 33 weeks, and we can go for in utero platelet transfusion if it is very severe. These are through the fetal medicine specialist we can give treatment. So how to treat these babies with neonatal alloimmune thrombocytopenia? By giving vast and irradiated maternal platelet transfusions. If the bleeding is severe and the baby's platelets is less than 20,000 per cubic mm. Autoimmune thrombocytopenia, ITP. Usually, we have to suspect the maternal ITP is there, maternal SLE is there, and maternal platelet counts usually decreased in this. And baby also have less platelet count, but it rarely causes intracranial hemorrhages. Treatment is IV immunoglobulins and steroids. So how to treat mother with ITP? Baby is born to mother with ITP. So if you diagnose before, only we can give, before delivery of the baby, we can give IV immunoglobulins or prednisolone 10 to 20 mg 2 weeks before delivery to the mothers. So platelet count in the newborn will be raised. And it's preferably, the platelets are less than 50,000 per cubic mm, then it's better to go for lower section cesarean section. And postnatally, if the baby is less than, having platelets of less than 50,000 per cubic mm, we can give IV immunoglobulins to the baby. Otherwise, no need of any treatment for the baby. So coming to the vitamin K dependent bleeding, that is otherwise called as hemorrhagic disease of the newborn. As I told you, it will be divided into early classical, and late. Early means usually first 24 hours of life only baby will have bleeding manifestation. Usually mother's antenatal history will be positive. 5% of the incidents will be there, like mother received anticonvulsant like phenytoin and phenobarbital or INH, like antitubercular drugs like INH. Then other mother anti-malarials like quinine, quinidine. These are the risk factors will be there, and baby may have chances of intracranial hemorrhage, umbilical bleeding, and upper GI and lower GI bleeding, and bony hemorrhages. So here we have to treat with 1 mg of vitamin K immediately, and if needed 6 hourly per 2 weeks. Coming to the classic HD and immunogenicity of the newborn, incidence is very less, like 0.01 to 1%. Usually they will manifest after first 24 hours, but before 1 week. So here causes of idiopathic, maybe maternal drugs may be there. Intracranial hemorrhages, umbilical bleeding, and GA bleeding, and ENT, nosebleeds, they'll present. And here treatment will be 0.5 mg if the baby's birth weight is less than 1.5 kg and baby birth weight is more than 1.5 kg. You can give 1 mg vitamin K at birth. That's why all newborn baby will give vitamin K injection at birth to HDN. And late HDN is very, very rare, less than 0.02%, and usually manifest after 2 weeks of life. Here causes will be malabsorption, like fat malabsorption syndromes. So fat malabsorption leads to vitamin K deficiency. It's a fat soluble vitamin. And any liver diseases like cholestatic jaundice and any other hepatitis, congenital neonatal hepatitis, and all those conditions affecting the liver will lead to vitamin K deficiency. And exclusively breastfed baby, the mother is already vitamin K deficiency, baby not received vitamin K at birth, also they can present with late HDN. And intracranial hemorrhage, GA bleeds, and nose bleeds, and skin bleeds into the skin. This will be the manifestation. And vitamin K at birth to prevent and repeat intramuscular vitamin K every weekly. If the baby is having malabsorption or sick baby, and enteral feeds, complete enteral feeds, parental feeds, not given any feeds enterally. GA bleeding is not there, only parental feeds. IV feeding is there, baby, a very sick baby, or a baby on broad spectrum antibiotics. Have to give vitamin K intramuscularly every week, once in a week, until the baby recovers from the liver disease or the baby recovers from the sickness. So how this invasive disease of newborn occurs, especially vitamin K dependent factors like 2, 7, 9 affected the vitamin K deficiency. So transplacental passes of vitamin K is very minimal physiologically, and also human milk is contains very low vitamin K. That's why the babies request vitamin K to be given from the external source. And also colonization of bifidobacteriaceae, which does not synthesize vitamin K in the exclusively breastfed babies. So if it is not there, also colonization of this bacteria which does not synthesize vitamin K. So then also they will develop vitamin K deficiency. So coming to the differences between platelet disorders and coagulation disorders, clinically, how will you differentiate before going for the investigations? So site of bleeding also gives some clue to you. The bleeding is from the skin, mucous membrane, most probably platelet disorder. The bleeding is into the soft tissues and joints and muscles, most probably coagulation factor deficiency. And petechiae purpura are more common with platelet disorders, not in coagulation factor deficiency. Here, ecchymosis, bruises will be more common. Ecchymosis small and superficial in case of platelet disorder, large and deep in case of coagulation defects. And hemarthrosis, bleeding into the joints and muscles, extremely rare in platelet disorders, very common you can see in hemophilic children. And bleeding after surgery immediately will be there in case of platelet disorders, but delayed in case of clotting factor deficiencies, like after 12 days, like that. Examples for platelet disorders are von Willebrand's disease and immune thrombocytopenia. And coagulation, hemophilia A and B is the examples. So coming to the laboratory test, we have to test for platelet disorders. Bleeding time we will do BT, that is bleeding time. This usually assess the function of platelets and also interaction with the vascular wall. Usual bleeding time is 4 to 8 minutes. Here, in case of platelet disorder, bleeding time will be prolonged more than 8 minutes. Platelet count is also will be decreased in case of platelet disorders. Normal is 1.5 to 4 lakhs per cubic mm. Here it decreases to less than 1 lakh per cubic mm. And platelet functional assay is also abnormal, especially if you do it with epinephrine or thromboplastin and ristocin test. These will be abnormal in case of Glanzmann's thrombocythemia and Test for coagulation factors. First, initially we have to do prothrombin time and activated partial thromboplastin time. So prothrombin time usually extrinsic clotting factor deficiency it indicates, and PT partial thromboplastin time usually initiation at the level of 7, 9, and 11 factors deficiency, and usually it is around 25 to 40 seconds. PT is 12 to 14 seconds. Usually it indicates defects in the 2, 7, and 5, 10 factor deficiencies. And thrombin time we can do fibrinogen D-dimers. I say D-dimers will be increased in case of disseminated intravascular coagulation. And peripheral smear always gives clue. If you examine peripheral smear, usually you can see decreased clumps. There is platelet deficiencies. So platelets size and granulation of platelets also will be indicated in case of thrombocytopenia, and fragmented RBCs is observed in case of disseminated intravascular coagulation. So these are the clues given in case of peripheral smear examination. So this is a gist, like tabular form you can remember easily. So baby, you have to see whether the baby is sick or healthy. Sick baby, platelets are decreased, PT, APTT both are prolonged. Always think about sepsis with disseminated intravascular coagulation. Only platelets are decreased and PT and APTT are normal in case of sick baby. You have to sepsis and necrotizing enterocolitis. This is new for newborn baby. And the platelets are normal, but PT and APTT are prolonged liver disease we have to suspect. And the baby is very sick, but all are normal, platelet, PT, APTT. It's a stress-induced GA bleed. If the baby is healthy, platelets only decreased, others are normal. You have to think about ITP, that is immune thrombocytopenia, or occult infection we may be missing, and thrombosis or bone marrow aplasia or infiltration, like Fanconi's syndrome. You have to think. In case of platelets are normal and PT, APTT are prolonged, baby is healthy, so we have to think about vitamin K deficiency. Platelets are normal, PT normal, APTT only affected hemophilias. All are normal, healthy baby. It's maybe local factor like local trauma, like anal fissures, like that we have to think. So screening test, complete blood count, peripheral smear, and PT, APTT. If thrombocytopenia is there, then you have to go for as a PT or APTT are prolonged. Both are prolonged, most probably Dicker sepsis. So PT and APTT normal, only thrombocytopenia, ITP, or bone marrow hypoplasia, or occult infection and thrombosis. Thrombocytopenia is not there, PT and APTT we will do. Then if it is both are abnormal, then early liver disease or factor 8, factor 7 deficiency or warfarin we have. Both are normal, then factor 13 deficiency or von Willebrand's disease where factors will be normal, excepting type 2B, which is where factor type 2B is needed for the factor 7 activation, platelet function disorders and vascular disorders. So management, how to manage a baby with bleeding manifestation. You can give parental, if you think it's vitamin K deficiency or liver disease, we have to give before going for the investigation, we can give parental IV 1 to 2 mg of vitamin K and repeat if bleeding is still further continuing. Platelet transfusion, if the bleeding is severe and the platelet count is less than 50,000, you can give platelet transfusion. Fresh frozen plasma, which in case of suspected hereditary coagulopathies like hemophilia, factor 8 is not available immediately, you can go with fresh frozen plasma 10 to 15 ml per kg. It increases the factors by 10 to 15 units per kg. And if blood loss is very severe, if the baby is going for shock, you can give whole blood transfusion. Usually we will start with 10 to 20 ml per kg. And you can give cryoprecipitate 1 unit per kg in case of dysfibrinogenemia. So how to prevent bleeding in neonates? So give universally to everybody. If the baby's weight is 1.5 kgs, 1 mg of vitamin K intramuscularly immediately after birth. The baby's weight is less than 1.5 kg, then you can give less dose, that is 0.5 mg per kg. 0.5 mg intramuscularly, not per kg. Okay, give 1 mg intramuscularly to all babies above 1.5. Give 0.5 mg intramuscularly if the baby's weight is less than 1.5 kg. This is universally immediately after birth. We will give to all babies to prevent the HDN, that is hemorrhagic disease of newborn. The baby is in TPN, that is total parental nutrition. So we are not giving anything from the mouth. only IV nutrition. Then we have to give intramuscular this vitamin K injection weekly, every weekly until baby infection is treated and babies become until baby becomes normal. So if the baby is TPN, that is total parental nutrition, if the baby is receiving broad spectrum antibiotics and sick neonate, you have to give weekly once vitamin K injection. Give 10 mg of vitamin K in IM or IV to the mothers. Before delivery, the baby mother is on phenobarbital, phenytoin, antitubercular drugs, or coumarins, or quinine, all those drugs which can cause thrombocytopenia and bleeding in the baby. If you know before delivery, we can give 10 mg to the mother. So, any doubts regarding bleeding neonate? Anybody is having any doubts? You can ask me. Jyoti Prakash?
Ma'am.
Any doubts? Any doubts? This usually they will not. Only hemophilia you can get as a question. Others only thrombocytopenia, ITP. All those are for 4 marks question or 2 marks questions only. But practical purpose, you should know how the baby with bleeding, dialysis, or coagulation defect will manifest in the newborn period. How to prevent, because in newborn period intracranial bleeds will have long-term consequences. Lifelong they have to suffer with this developmental delay, intellectual reduction in intellectual IQ deficiency, and seizures and cerebral palsy. For that purpose, if you diagnose and prevent intracranial bleeds, the baby will become normal. For that purpose, you should know bleeding neonate. Okay, not for exam purpose or marks. Any doubts are there? Any doubts?
No, ma'am.
Okay, then I will end the meeting.
Thank you, ma'am.
Okay, thank you, bye.
Thank you, ma'am.